I've had experience, get the gray hair, the white hair with that, but I've had a great opportunity. And as you'll see, I love to be able to teach, to go through these things. I've worked as advisors for different groups over time, and right now I primarily work in clinical practice and teach in various ways, and do work with the Vedadica people in the Sierra Madres in Mexico as a traditional healer. So we're going to focus today on these performance objectives that really focus on digestion and absorption, that are honing in on understanding this functional somatic syndrome called irritable bowel syndrome that so many people have. It's a condition of huge importance that we see. It's often minimized or stigmatized, or that's not a real issue that's going on. But when we get into it, we'll see that the issues for individuals who have it have an incredible cost. And being able to dissect into understanding the various root causes of what is causing this symptom complex is really what our focus is going to be on over this lecture and a few other lectures. And you'll begin to see that dig in acronym, that approach that we take that helps us to be able to understand exactly what's going on. And then, of course, we'll drive our personalized treatment that we have for individuals. So we see this constellation of symptoms. And when we have a dysbiosis, a dysfunction in the balance of the microbiome of the gut, or parasites or infection or food reactivity, surgery, poor diets, medications, all of these things can lead to inflammation and disruption of the gut microbiome. Then there's intestinal permeability and barrier dysfunction that leads that increase in permeability that ends up leading to incompletely digested foods or bacteria or parasites moving into the lamina propria and stimulating the immune system and actually causing, immunologically mediated reactions. And as we've already heard, what happens in the gut does not stay in the gut. It has consequences systemically for an individual. So when we look at this piece, and you'll hear more about it tomorrow morning by Dr. Boehm in talking about intestinal permeability, there are many, many different factors that lead to this alteration in intestinal permeability. And I like to say it's not the food's fault. Many people, when they're looking at permeability issues, they say, what food am I sensitive to? And quite often when you have intestinal permeability, you're most reactive to the foods that you're eating, because they're not being digested completely and they're moving through into the paracellular space into the lamina propria and stimulating the immune system. And as we see, that happening, that can lead to a systemic inflammation and systemic disease that's going on. So when we take a look and step back and say, well, IBS is really a big issue. And as we've seen, the thought leaders in functional gastroenterology have been meeting in Rome every 5 years. Now, the most recent Rome 4 demonstrated that about a quarter to a third of the people in the United States end up having functional GI problems that are occurring, which includes GERD, which includes IBS, which includes functional abdominal pain, which includes constipation. And we find that in the people who have these issues going on, really a quarter of the population, when we look at their patient-reported outcomes measures, we find that their mental health is actually worse than people with major depression, and their physical health is worse than people with type 2 diabetes. And so when you put that all together, you end up seeing that across the entire United States, because of loss of work and loss of productivity and decreases in overall ability to work, the cost is more than $20 billion a year for irritable bowel syndrome. So what is it? What's going on here? We can see in this diagram on the left-hand side, when you have a normal microbiome and you don't have permeability issues and inflammation is in balance and there is normal transit and normal bowel movements, we have a normal mental status, and we feel healthy and well. But when we actually have an imbalance in the microbiome and or intestinal permeability and or hypersensitivity that's going on due to inflammation and or abdominal pain and or altered motility due to altered vagal nerve function and other issues, we'll see a disturbed gut-brain axis, we'll see chronic stress. Those things are affected by what's going on in the gut microbiome. I'll talk more about that on day 3 on Sunday. And so we see this imbalance that goes on in this complex condition. Now, within the standard framework, what is done is it's usually broken down into, well, is it IBS with diarrhea? Is it IBS with constipation? Or is it mixed? And, and what we'll be looking at here is there's a lot of different factors that go into this. So when we take a decision tree of saying, how do we begin to approach this? We look at the information where we'll use this go-to-it model that is part of the functional medicine operating system. And first we gather the information. Gathering information, as we heard Dr. Lipsky talk about earlier today and Dr. Baum, and gathering diet histories, looking at what's going on with the ABCs, as we call it, the anthropometrics, the biomarkers, and the clinical indicators to see what's happening with this individual. We then organize that information around the IFM clinical matrix. And so we look at the antecedents, triggers, and mediators. We look at the modifiable lifestyle factors. We look at the mental, emotional, and spiritual factors that are going on. We look at the different nodes as we see to where is imbalance happening within that setting. And we go from there into this dig-in approach where we're thinking about, well, what's happening with digestion and intestinal permeability, the gut microbiome, inflammation, and the enteric nervous system, to be able to recognize patterns that we begin to see. And within those patterns, we can look at primary causes of irritable bowel syndrome, which can include digestive insufficiencies, dysbiosis, altered microbiome, pathologic infections that are going on, bacterial overgrowth, fungal overgrowth, post-infectious processes that continue to stimulate an IBS like symptom picture, looking at what's going on with food reactivity, as well as the role of the gut-brain microbiome axis and anxiety and stressors that go on. And as you'll see over the course of the next few days, all of these things are actually related to each other. So we can focus on digestion and absorption on the D. We can focus on intestinal permeability, which is actually going to have an impact on all of these factors that are going on if there is permeability. We can see those issues of the gut microbiome. And as we see, the gut microbiome is going to have an effect in multiple areas on dysbiosis infection and SIBO and SIFO. We look at what's happening with inflammation, and whether or not inflammation due to a previous infection may cause problems, or food reactivities that you'll hear me speak about tomorrow morning. And then we can also see the role of the enteric nervous system. So we take this dig-in approach to be able to help us more deeply understand exactly how to take the imbalances that are going on with an individual and define, well, what is exactly going on for this person, so that we can drive treatment recommendations that will really be truly effective. As we do that, again, within our go-to-it model, then we're going to talk to the person and engage what's going on and begin to understand some simple things. Is this related to inflammation? Is this related to a thyroid problem? Is this related to celiac disease? We're going to rule that out, and then we're going to go in and we're going to start to begin to understand, either treating empirically with diet first and moving forward, or moving more deeply into understanding exactly what's going on with the gut microbiome, with digestion, absorption, inflammation, and we'll be teaching you how to measure those things specifically so that you can personalize the treatment that's going on. and we'll look at symptomatic relief. We may try empirically to work with, some of those agents, such as prebiotics and soluble fibers, or agents that are going to help to stimulate movement, like vitamin C and magnesium, or other kinds of herbs that will help in the process. And then we'll take that and we'll relate that to those modifiable lifestyle factors. So in the end, we see a whole array of potential treatments that we can focus on and follow up from there. But in today's conversation, where we're going to be focusing, is back up at the top. We're going to be focusing on digestion and absorption. And I'm so pleased to have my good friend, Dr. Liz Boehm, join me here and take over. Thank you so much.
Thank you for laying that groundwork on and going through the IBS clinical decision tree. There's so much good information on this decision tree. So, take some time, and we'll be circling back to this decision tree throughout the weekend. But there's a lot of, little nuggets on there that you might find helpful. And this is another handout or form that you can print out and have available for you to circle back with, like we were talking about earlier today with the GI decision tree, right? So as Patrick mentioned, we are focusing on digestive insufficiencies or digestive sufficiencies, right? Digestion and absorption. That is the first D, and that's what we're going to focus on for the next 65 minutes or so till Dan and Patrick come back in and we start to go through some questions. So I love to start with a case because it will help ground us and, remind us of why we're doing what we're doing. And so this is a case of a 65-year-old woman who came to see me with weight loss and GI symptoms. And, she was always thin. So she's 5'8" and 115 pounds. So yes, she's thin. But over the last couple of years, her weight even dropped further to 100 pounds. And she had a history of heartburn, diarrhea, bowel incontinence, constipation, nausea, bloating, and abdominal pain, and more hair loss. And of course, because of her age and her significance of her symptoms and her weight loss, she had a large workup, and her colonoscopy was normal. Her endoscopy only showed a slight hiatal hernia. She had biopsies for celiac disease, which were negative, and her conventional celiac testing was negative. CT scan that was normal, HIDA scan that was normal. She was placed on a gluten-free diet, which, I often do, but, she lost more weight with that. I think that with the provider who recommended this maybe didn't have a good nutritionist she could work with. And so she ended up losing more weight, and she was placed on Ensure, which caused more diarrhea and some low blood sugar reactions. So here is her timeline, and I'm going to start to show, bring things up here. She is that chief complaint, right? So she's the 65-year-old woman with the weight loss and the diarrhea and the heartburn. And she was born at term, bottle fed, but she was a colicky baby. She was always, irritable as a baby. So I put that down here at the beginning of her timeline. And what you'll see here is she had a lot of headaches when she was young. And she treated those headaches with a lot of Tylenol. She was underweight, her highest adult weight was 115 pounds, ended up having 2 normal, healthy pregnancies. I put up here under mediators, she was always a worrier. She did consume well water. And she went into menopause at the age of 50. And at that point, she started to have more heartburn that was then treated with a PPI and then Zantac a couple times a day. I said up there under mediator, she was sensitive to supplements, But she really feels that the death of her parents around the age of 55 was a major trigger for her. And at that time, after that time, she started to have be more anxious. She started to have more GI symptoms. She was diagnosed with irritable bowel at the time, and also had the heartburn and gastritis that they were continuing to treat. And she also developed a lot of urinary tract infections. She was postmenopausal and got into that cycle of urinary tract infections with antibiotics. And then things sort of cycled forward, and she really struggled with recurrent urinary tract infections and further weight loss. And then, as I mentioned earlier, she was given Ensure and put on a gluten-free diet, and as a result, started to, lost even more weight. She did have a diagnosis of SIBO in here as well. So one of the things that I think, and I mentioned this earlier this morning, about how important it is to make sure that our patients are getting enough food to heal, right? We want to make sure they're getting enough food to heal. So we do need to remove inflammatory foods, but what we always talk about in our practice, and when we're talking with our nutritionists, and we're all reflect back on this, of how critical it is that our patients are getting enough nutrition to heal. And that was one thing we focused on. So here's her ABCDs of nutrition assessment. So look at her BMI. She's 15, which is definitely underweight. Surprisingly, her biomarkers were pretty good. Her PFC MVP, like her protein markers, albumin, prealbumin, serum amino acids were pretty darn good. Her zinc and copper and iron were in the normal range. Her B12 markers, her methylmalonic acid and homocysteine and vitamin D and vitamin A were all normal, which is really surprising given her weight and her digestive issues. But on clinical exam, thin woman, she had a scalloped tongue, her nails were normal, and she had some diffuse nonspecific tenderness. And as I mentioned, she was on a gluten-free diet, drinking Ensure. Good news, her CRP is normal, her ANA is normal, her basic blood work was normal, she didn't have any parietal cell antibodies. But look at her DEXA scan, right? She's got some definite osteoporosis. And as I mentioned earlier, her testing for celiac disease was normal. Here is her stool test, and on stool test, on a comprehensive stool analysis, we see here it measures pancreatic elastase, and you can see here it's got the L, right, for low. So between 100 and 200 is considered moderate pancreatic insufficiency. We're going to talk more about that in the next hour and during this lecture. You also see on the stool test, she had high levels of fecal fat. And when they tested for bacteria, she did have a pathogen, Aeromonas caviae. And I don't always see, it's not very common that I'll see something come up in red on this stool test. So this was a significant finding, and we felt that it was coming from the well water that she was drinking and may have contributed to some of her symptoms. I also did a sucrose Brett test, and I'm going to circle back to this during this lecture, but just so you know, it was normal for her. So I want you to think about this over the next hour, right? What do you want to do next? What is your assessment and what's your treatment plan? And as I said, we're going to circle back to this case multiple times, but I just want you to start thinking about what you would do. And during this next hour, first, we're going to identify some critical factors for optimal digestion and absorption, and common factors that can inhibit the functioning of the digestive system. And remember, in that dig-in model, the D, this is the first D, digestion and absorption, that we are focusing on in this next lecture. And as you remember this morning or earlier today, Dr. Lipsky really talked about the assimilation, digestion, and elimination of foods. And, she spoke about those first three. We're going to talk next about digestion and absorption, and then circle back to motility at the end. So many of us know this, but the surface area in our digestive system is huge, right? It's roughly about the size of a half of a badminton court, or 30 to 40 square meters. And the reason we have all of the surface area, which is then accordioned into these villi in our digestive system, is so we can optimally digest and absorb all of the nutrients from our foods. So it's critical that we have a good working GI mucosa here. And here is a beautiful picture of the robust villi in an intestinal lining. It's just beautiful, isn't it, for all of that absorption. And as you know, when there is celiac disease, those villi get damaged. And you can see here on the right, there will be the flattened villi that happens with celiac disease, and why celiac disease is associated with so much malabsorption, maldigestion and malabsorption, because these villi are damaged and flattened. This is a beautiful system that we have. And as Dr. Lipsky was talking about before, the process of digestion starts even before we start to eat food, right? Just smelling the food or thinking about the fact that we are going to be eating. We release saliva in the mouth. Saliva contains an enzyme amylase, which starts to break down your food. And when you're chewing, you release this ptyalin, another alpha amylase, which breaks down the food even further. Through peristalsis, the food starts to move through the esophagus, through the esophageal sphincter and into the stomach. And in the stomach, there's a release of HCl or acid and pepsin, which then further breaks down the food in our stomach. It creates chyme. The chyme exits through the pyloric sphincter from the stomach into the duodenum. And in the duodenum, there's pancreatic enzymes come in, right? The proteases, amylases, and lipases. Bile is released into the duodenum for digestion. And there's also brush border enzymes in the intestine as well. And so much of the digestion and absorption occurs through the small intestine. And then that food then will leave through the ileocecal valve into the large intestine, where there's a lot of undigested fibers or indigestible fibers, both soluble and insoluble, which then feed all the good microbes in the colon and produce things like short chain fatty acids like butyrate, which is so critical for healing the gut lining and for food for the cells in the gut lining. And then a lot of water is absorbed through the colon. In the colon, we make B vitamins and vitamin K. And then the stool, after all of that occurs, all of that food will leave through the stool, through the rectum. It's an amazing system, right? That's full of mechanical breakdown and enzymatic breakdown and active and passive absorption, all regulated by both the central nervous system and the enteric nervous system. Really, this phenomenal system, so we can get all the nutrients our body needs for optimal health, right? I'm just being a nutrition nerd again, right? It's just phenomenal. But things can go wrong. They do go wrong, unfortunately, sometimes. And here's just a slide that sort of highlights where things can go wrong. First, that first X up at the mouth, if somebody is eating too quickly, not taking the time to chew properly, that of course can impact digestion and absorption and is a real important area that we always focus on. In the stomach, you'll see that X if there's not enough acid in the stomach for whatever reason. And we're going to talk about why that might be today. If the pancreas, there's an X in the pancreas, if there's pancreatic insufficiency, if the pancreas is not making sufficient digestive enzymes, or if the liver is not making a proper bile, or the gallbladder's been removed, and there's which can store the bile and allow for optimal digestion of our fats as well. There can be an issue with bile insufficiency. And of course, there's enzymes in the brush border of the intestinal lining. And there can be issues with digestion if those are damaged as well. And we're going to go through all of those things today, because as we know, there's a lot of consequences of poor digestion, right? So the causes may be altered transit time, the villus atrophy we spoke about, imbalanced bacteria in the gut or dysbiosis, low levels of enzymes or stomach acid, maybe somebody's taking an acid blocker, not chewing properly, and then what the consequences are, there's not sufficient vitamins and minerals and nutrients for all the systems in our body to work properly. In addition to that, the foods might not be broken down sufficiently, and as a result, they can be more allergenic in the body and be more triggering to cause more inflammation for somebody. So remember, maldigestion means that you're not digesting or breaking down the foods properly, and malabsorption impact is referring to what gets absorbed into the body. The major part of absorption occurs in the duodenum and the proximal jejunum. And here this just sort of breaks down where all of our nutrients are being absorbed. So you'll see here the proximal small intestine, where a lot of the macronutrients are absorbed, as well as iron and folate and water and electrolytes. In the distal small intestine, right, in that ileal area, in the ileum, B12, of course, and bile salts are reabsorbed at that point. And in the colon, a lot of water and electrolytes are reabsorbed as well. This slide really talks about, well, what are some things that may cause maldigestion? So what are some things that may result in the body not breaking down the food like it should? So maybe there's an issue with bile acid deficiency, conjugated bile acid deficiency. You know, what happens with SIBO, or small intestinal bacterial overgrowth, can deconjugate bile salts and bile acids, so then they don't work as well. So it can become a vicious cycle of infection in the gut, creating the bile acid to not work as well, and it can be a further maldigestion and malabsorption occurring. If there's pancreatic insufficiency, maybe chronic pancreatitis, that of course could result in maldigestion. If there's damage to the brush border in the intestine, maybe with Crohn's disease or celiac disease, then there can be a deficiency in those brush border enzymes. Or, as I mentioned before, a SIBO or a parasitic infection can impact the digestion of our B12 and macronutrients. So how about malabsorption, right? We were talking about malabsorption. In addition, that mucosal disease that can occur with Crohn's or celiac, or removal of a part of the intestine, can result in many issues in terms of absorption of your nutrients. We do know that if there's, you always want to check with your patient if they've had any resection in the bowel, like around the ileocecal area, how much has been resected. If more than 60 centimeters of the ileum has been removed, you're thinking about what is going on with B12, because we know that B12, it's bound to intrinsic factor, is absorbed through the ileum. So you're wondering, you're asking that question, what's going on around the ileocecal valve? Do I need to think about B12? And here's just a review, of some of the problems that occur when there is problems with malabsorption and maldigestion, and what you might see on clinical exam or when you're getting your signs and symptoms from your patients. So they may talk about this diarrhea or floating stools, and then you're thinking about fats, or of course the glossitis is making you wonder about the B vitamins. And just to remember, you have this in your toolkit. This is the biomarkers that are divided into your protein, fats, carbohydrates, minerals, vitamins, and phytonutrients, and all the biomarkers that you can do to be able to assess somebody's nutritional status. So that's something you can go back to and look at if you haven't already done that. So next, we're going to jump into laboratory tools. How do you know? How do you know if somebody is malabsorbing or maldigesting? And when would you want to prescribe a digestive enzyme or betaine or some bile salts? How do you know? And what I like about this slide here, what you'll see at the bottom, or how we divided this lecture, right, is we divided it into three sections. So we've got pancreatic enzyme assessment and treatment, gastric acid assessment and treatment, and biliary assessment and treatment. And so we're going to think about this in these three different sections here in terms of digestion and absorption. Many times they overlap, or there may be more than one thing going on, but this will just help us sort of focus a little bit and say, okay, what's going on with this patient? The first thing we're going to talk about is pancreatic enzyme assessment and treatment. So, we have many different pancreatic enzymes, the lipases, the proteases, the amylases. This slide also highlights up at the top those enzymes that are not just coming from the pancreas. So in the mouth, the amylase, in the stomach, there's the pepsin, and then those brush border enzymes, the maltase, sucrase, and lactase that are on the border in the small intestine. All of those come together, and we're going to be talking about those in this section here. So what are some signs and symptoms? How do you know if somebody has pancreatic exocrine insufficiency? Sometimes it's confusing. You're not sure. Do they have bacterial overgrowth? Do they have SIBO or SIFO? Do they have a problem with pancreatic enzymes? Sometimes a lot of the symptoms overlap and it can be kind of tricky, but we're going to try to sort of tease that out a little bit. So some typical signs and symptoms of having inadequate pancreatic exocrine pancreatic enzymes are fatty stools, diarrhea, gas and bloating, stomach pain, weight loss, as I talked about with my first patient. And then there's a lot of disorders that can result in problems with pancreatic enzymes. You may see they may come in and talk about abdominal pain or weight loss or muscle wasting because they're not absorbing their protein, or fatty stools or bulky stools, abdominal bloating or gas, stomach pain, edema, because they're not absorbing enough protein. And then a lot of those nutritional deficiencies seen on biomarkers and physical exam. Low pancreatic enzymes are associated with many diseases, from this is a whole list of Crohn's to chronic pancreatitis to celiac or GI surgery or bypass surgery. Diabetes, for people who are insulin dependent diabetics, 25 to 50% have pancreatic insufficiency. So just important to be remembering that and thinking about it for many different patients. What causes low pancreatic enzymes? Well, damaged microvilli. I'm going to start here on that left-hand side. So if somebody has celiac disease and those villi have been damaged, as I showed you the picture with earlier, there can be some deficiencies in those brush border enzymes. Then that CCK is not stimulated, cholecystokinin, and as a result, CCK stimulates the release of pancreatic enzymes, and that can be a reason. Toxicity can be a reason. Stress. We need to be, activating that parasympathetic nervous system for all of our digestive enzymes and acid and bile to be working properly. Nutritional deficiencies, this can become a vicious cycle. We need a lot of nutrients to be able to produce enzymes. And so that can be a feed-forward, unfortunate cycle. Imbalanced pH. If you have a not sufficient acid in your stomach, if you have low stomach acid, maybe you're not producing it or you're on an acid blocker, well, then what happens is if there's not enough acid in the duodenum, then secretin is not released. And secretin is that hormone that then stimulates pancreatic enzymes to be released. So as I was mentioning earlier, sometimes these overlap a little bit. Food inhibitors, oxidative stress, alcohol, all of these things can contribute to low enzymes, pancreatic enzymes. We have mentioned this before. These are the brush border enzymes that we're talking about. And, if you have insufficient lactase or sucrase, that can result in problems like lactose intolerance, fructose intolerance, and sucrose intolerance. And, fructose malabsorption is a definite issue for many of our patients. And we know that hereditary fructose intolerance is not very common, but about a third of us are not very tolerant to fructose at some level. And so important for us to be paying attention to. And unfortunately, as you know, we're just consuming way too much fructose, and that compounds the problem as well. And many times the symptoms are, fall into that irritable bowel symptom category. And so again, can be tricky to tease out, but something to remember. When people have Crohn's or ulcerative colitis or celiac, that also contributes, as we were mentioning, to fructose issues or lactose issues as well. So how do we assess it? pancreatic elastase is a great biomarker. It's well recognized. It's a standard it's a standard biomarker that can evaluate all of the enzymes, all of the pancreatic enzymes that are produced. So pancreatic elastase gives us an impact, gives us the information about level of amylase, lipase, and proteases all together. And it's not typically impacted by somebody being on a digestive enzyme, right? And you can do this test through conventional labs, LabCorp or Quest. You can also do this test. It's often part of a comprehensive stool analysis. And what the general norm is, a normal is, 500 to 700 or so. 100 to 200 is considered moderate pancreatic insufficiency, and less than 100 is severe pancreatic insufficiency. And this test is even more accurate when it's more sensitive for severe pancreatic insufficiency. So it's often something you'll do when you have a patient who comes in with diarrhea, weight loss, malabsorption, abdominal pain. And here's an example of somebody who is moderate pancreatic insufficiency, right? That 100 to 200. And another moderate pancreatic insufficiency example. And here's somebody with severe pancreatic insufficiency, less than 100. So what do you do about it? What can we do? We've got this result back. Well, there's some foods that can be helpful for production or stimulating digestive enzymes, and we can also give supplementation or medication. So this is really a fun slide to look at because you can notice all the different food sources, herbs, spices, foods that can trigger enzyme production and other things that help with digestion, such as bile secretion. So here, talking about ginger and curcumin can increase the amylase production. Curcumin can also increase lipase production. Coriander and onion can stimulate those brush border enzyme productions. In bitters, we have a lot of herbs that will help, and that's one of the reasons bitters works, is it helps to stimulate production of all of these enzymes. You'll see here mint and fennel will increase bile secretion, as well as lipase and amylase production. So when you are choosing, let's say you decide based on your test results or your patient's symptoms that you want to use a digestive enzyme, one of the things, this is just some of the things to look at when you're picking a digestive enzyme, but you're really thinking about what is it that you want to support? What do you suspect their major issue is? Do they have a combination of low lipase, amylase, and proteases? Or is it more that they need to focus on supporting fat digestion, for example? So you think about that when you're making your decisions. And I think what's important is just getting to know a few different types of digestive enzymes. So you have some options, and then you get to know them well, and you can experiment with your patients using different ones. So there's a lot of options here under digestive enzymes. There can be, you can get animal-based ones, so they're porcine, usually, typically pigs or cows, but typically pigs often. Pancreatic enzymes. There's also enzymes that are plant-based, grown on aspergillus. And then there are some that are food-based as well, like papain and bromelain. And so you want to get to know some of the different types of enzymes. Often the animal-based, the porcine enzymes are more powerful. So depending on what kind of results you're getting from your patient or what you think you might need to support, that may be a good place to start. You can also use pancreatin to digest protein. Your patient may just need an enzyme that supports lactose digestion or gluten enzymes, and we'll talk about that in a second. There are prescription-based enzymes. You probably know about these. These are all FDA approved, can be ordered through a physician. They are prescription-based enzymes. The amount of the enzyme is based on the amount of lipase in it. So you'll see there all sorts of different strengths. For example, of Creon, 3,600, 6,000. That's really just giving you a sense of the amount of lipase in that enzyme. And a brand like Creon will have a website where you can go to and put in the patient's weight and symptoms and get a sense of how much you want to prescribe for them. And this is, a powerful pancreatic enzyme. From a supplement perspective, you can get this is some examples of some animal-derived pancreatic enzymes. So pancreatin, they'll just give you some ideas of different strengths. And what we have in your deck, which I'm not going to show you here, but it will compare the different units and what you're getting, because sometimes it's confusing. You'll look at one bottle, it'll say it's this amount, and what does that equal with a different type of a supplement. And there is some information of that in your slide deck. In addition, what I would say is it's a lot of trial and error with people. Sometimes you start them with one or two, and you notice that when you increase it, they have better symptom relief. Here are some plant-derived digestive enzymes or aspergillus-derived. And what you'll notice here, this product number 2 has alpha-galactosidase. That's the enzyme that helps break down the complex carbohydrates found in beans. So if you think that's what your patient might need, you would look for an enzyme that would have the alpha-galactosidase in it, for example. Here are what enzymes might look like if they're supporting lactose breakdown or lactase enzymes. And for gluten, there are some enzymes that can help break down the proteins in gluten. DPP4 and protyl endopeptidases can help with breaking down some of these proteins in gluten that may help your patient if they're gluten sensitive and they may have some exposure to gluten. It's important that we are not recommending these enzymes for people with celiac disease and saying, oh, just in case you get exposure, because we don't think that these enzymes are necessarily going to be protective enough for those patients with celiac disease. They really just need to be avoiding gluten. And then brush border enzymes. There's a bunch of different brush border enzymes out there, both prescription, like Sucrade, as well as supplement ones that really support those enzymes in the brush border. So if you suspect that your patient has inflammation in the small intestine and that's why they're not digesting as well, these may be a good place to really support. And I had mentioned earlier about a sucrase insufficiency or deficiency, and here is just some information about that. So you can have primary or congenital sucrase deficiency. It's not very common, though it's more common in certain ethnicities, and it's often found where a child or a young adult will have difficulty gaining weight and have a lot of GI symptoms. But there's also secondary or acquired sucrase deficiency that can be often misdiagnosed as irritable bowel syndrome. And it can happen when there's damage to the villi, and patients can come in with bloating, abdominal pain, and diarrhea. And it is felt to be, this is one study looking at, well, if patients have irritable bowel symptoms, IBS-like symptoms, maybe even up to 35% have some sucrase deficiency, which is interesting. And here is a test result that I did on a patient of mine who came in with weight loss, abdominal distension. Her pancreatic elastase was severely low at 60, and we did this breath test on her, and she also had low sucrase levels as well. And in that situation, you may be replacing sucrase with either a pharmaceutical or supplemental form. And then there's the food-derived. I talked about this earlier, papain and bromelain. Okay, so now we got a polling question. And so pancreatic insufficiency may produce or contribute to which of the following? So you guys go in there and select all that apply. So I'm going to give you a clue here. It's not just one, right? So it may produce or contribute to which of the following? Is it steatorrhea or diarrhea, fatty stools, loose stools? Is it high pancreatic elastase, SIBO, nutrition insufficiencies? What do you think? Yep, right. Oh, you guys are so good. You're so good. You're right. It is actually three of them, three of the four. So when there's pancreatic insufficiency, you can have fatty stools and diarrhea. It is associated with SIBO. Both the infection itself can impact the amount of or the release of the pancreatic enzymes, and of course, it's associated with nutritional insufficiencies. But what it's not, it's if you have pancreatic insufficiency, you're going to have low pancreatic elastase on testing. So that second one there is not correct. You won't have high pancreatic elastase. It'll be the opposite. Okay, so thinking about my patient, remember my patient, 65 years old, weight loss, GI symptoms. Does she have pancreatic insufficiency? Yes, remember she had that low pancreatic elastase? So I'm going to have you continue to think about that and remember what is it that you may consider for her. While you're thinking about that, we're going to go on to gastric acid assessment and treatment, right? The gastric acid assessment and treatment. So remember the stomach is producing 2 liters of gastric acid a day. It is phenomenal. That gastric acid is full of water and hydrochloric acid to lower stomach pH or increase acidity of the stomach. It's full of electrolytes and mucin and pepsin to break down protein. And stomach acid is critical. It's critical for absorption of our minerals, absorption of our B12, and breaking down our protein. Right? It begins that process of protein digestion. Stomach acid, the gastric acid will convert pepsinogen to form pepsin, which helps with breakdown of proteins. Stomach acid is critical to prevent unwanted microbes from getting in the body. So, not having enough stomach acid can result in more infection in the GI system. It can also result in more infection in the lungs, for example. It's been associated with more pneumonia. Right? So you want to have enough stomach acid to prevent bugs that shouldn't be getting into the body from getting into the body. And stomach acid is critical for absorbing minerals, calcium, iron, and some of these other minerals as well. So why are people getting low in stomach acid, other than if they're taking a medication that blocks it? Well, it's estimated that as we get older, that we produce less stomach acid. It's estimated that 60% of people in Japan over the age of 50 have low stomach acid. So it is something we see as we get older. We know that parietal cell antibodies, which are is an autoimmune reaction where the body attacks the parietal cells in the stomach, which produce acid, right? That's actually quite common. It's estimated between 7 and 19% of the general healthy population have these parietal cell antibodies. Not all of those antibodies are going on and creating low stomach acid, but for many people they are. So it's an important thing for us to be paying attention to. Of course, surgery, aging, as I mentioned, stress, H. pylori, PPI use, severe iron deficiency, all have an impact. And if you're not getting in enough calories, you won't have enough nutrition to be able to produce stomach acid. What are signs and symptoms? So really that bloating or belching right after eating. So 15 to 20 minutes after you eat, you start to feel really bloated right away or having belching. It feels like food's sitting in your stomach, especially protein-rich foods. They're not moving through. And a lot of times I notice with my patients, they just stop eating a lot of protein-rich foods. So they sort of start to cut back themselves. Heartburn or GERD-like symptoms, dyspepsia, constipation, nausea, vomiting. And sometimes people don't have any symptoms at all. And you might just start to notice labs like low amino acid levels, low protein levels, the ridges on the nails, right? Hair loss, low iron, and low B12, and you start to think, well, maybe they have some low stomach acid. As I mentioned, some of the consequences of low stomach acid can cause SIBO, or small intestinal bacterial overgrowth, because you need to have enough acid in your stomach to prevent those bugs from overgrowing. Parasitic infections, H. pylori and Candida, iron deficiencies, mineral deficiencies, osteoporosis, B12 deficiencies. Here's a whole list of diseases associated with low stomach acid. A lot of things are associated with it, from celiac to autoimmune disease. Pernicious anemia, or having those antibodies against your parietal cells, is an autoimmune disease. So it's tied in with all these other autoimmune diseases that we know of. So how do you assess it? Your GI doctor, the gastroenterologist, can do a Heidelberg test or a smart pill. But sometimes if you're not, a GI doctor, or you're doing primary care, you may be doing testing that looks at products of protein breakdown, these putrefactive short-chain fatty acids. So remember, if protein is not properly digested because of low stomach acid, then protein that hasn't been properly broken down will find its way into the colon and feed the colonocytes, producing these products of protein breakdown, or putrefactive short-chain fatty acids that can get picked up on stool testing. I'll show you a picture of that in a minute. Empiric testing, you may just sort of try with some stomach acid to see if it helps your patient feel better. You may do a gastrin level. If somebody's not on a PPI, you can look at gastrin. Sometimes if that's elevated, it'll be a sign that they're low in stomach acid. Of course, you can look for parietal cell antibodies or signs of pernicious anemia with a low serum B12 or an elevated methylmalonic acid or homocysteine. Here are some of the Heidelberg or smart pill tests that can be done. And here on a comprehensive stool analysis, this was a patient of mine, a 31-year-old with long-term digestive issues and weight loss. And see how we see here these products of protein breakdown, the valerate, isobutyrate, and isovalerate are elevated, which indicate that there's some undigested protein that is making its way into the colon and producing these products of protein breakdown. In addition, you see here that she's got her pancreatic enzymes are low as well. And so there may be a combination of things going on for her. And when we gave her pancreatic enzymes, porcine pancreatic enzymes, and betaine HCl, her symptoms improved, her weight loss stopped as well. Okay, so remember, when you see that high valerate, isobutyrate, isovalerate, it could be low stomach acid, resulting in poor protein digestion. It could be low protein digestive enzymes, low levels from the pancreas. And it could also be some brush border enzyme issues as well. And SIBO. All of those things may result in that test being high. So as I mentioned, sometimes, you're like, okay, I'm wondering, maybe my patient has low stomach acid. What can I do? Maybe you can just do a trial, or often I will just do a trial of betaine HCl. And betaine HCl is a stomach acid. You take it with a meal. Usually I tell my patients, you start eating and then you take some betaine HCl, and then and there's a wonderful handout that IFM has. I'll show you a picture of it in a second. Typical tablets contain between 350 and 750 milligrams, and you typically work up. But what I will say is, if your patient has any symptoms at all, maybe they feel warmth in their stomach, burning, heartburn, just stop the betaine HCl, that it's not for them. If they have a little gastritis in their stomach, that they're gonna feel poorly when they start it, and you're not gonna want to use betaine HCl. But if there's no change, or they feel that there may be some improvement, but maybe not as much improvement as they want, you can slowly continue to increase. And people typically increase up to 2,500 milligrams with each meal. Again, you sandwich it between food. You take a bite of food, take the betaine HCl, and then continue to eat. And especially with protein-containing meals, though I like all my meals to contain protein, definitely discontinue or cut back if there's any issues. And if there's any problems with ulcers or gastritis, or they're taking anti-inflammatory drugs, this is not something you want to use. Here's the toolkit item I was mentioning. And so sometimes we do a baking soda test, and you're going to have the opportunity to do this test on your own in the post-course experiments that you do with us. So you'll be able to try this on your own. And it's a way to kind of see, could this person, or does my patient have low stomach acid? You give them a quarter of a teaspoon of baking soda and 4 ounces of water. You drink it on an empty stomach. And typically, if they have sufficient stomach acid, they should have some burping. CO2 is produced and burping will form within the first 5 minutes. So if they have burping, you can go, okay, maybe that's sufficient stomach acid. But there are lots of times where I just suspect low stomach acid, and I don't always do the baking soda test. I might, as you can imagine, it's not a perfect test, and I might just do a trial of either betaine HCl or even bitters to see if that helps. So how can you support stomach acid? Yes, betaine HCl, because we want to have good stomach acid, but bitters is wonderful. Bitters can be helpful as well. Vinegar, apple cider vinegar, digestive enzymes can help as well. And, really helping your patient get on a good breathwork program, stress reduction program, and acupuncture. Bitters are great because this is just an example of what a typical bitter product would look like, and all of the different herbs in it. But as I was mentioning earlier, they can stimulate production of acid, but they also will stimulate production of pancreatic enzymes and bile. And many times all of that together is what your patient needs. So sometimes if you want a more gentle approach or a more comprehensive approach, bitters are a nice way to go. And as I was mentioning, apple cider vinegar, some people really notice that that's helpful as well for their symptoms. Okay, so my patient, we're going back to my patient. She was that 65-year-old woman with weight loss, and did she have hypochlorhydria? Did she have low stomach acid? Well, it's possible, because she was on an acid blocker, and she had been on a PPI in the past. And but I did check her for parietal salt antibodies, and they were normal. And we did try some bitters and betaine HCl, and she did find them helpful. But she could only take 1 or 2 betaine HCls, or if any more, she got some discomfort or burning. Okay, guys, we're going to go on to another polling question. But this is a great time for you to stand up while you're doing this polling question, because I think we need to move around for a second. And at the same time, you can also name a common trigger or mediator that can result in maldigestion or malabsorption. And remember, if it's more than one word, please hyphenate. And as I said, type in what you got, but also stand up and move around, because I'm going to give you a couple minutes to, maybe not a full couple minutes, but a little bit of time to answer this one. Maybe do a little stretching. Yes. Moving. That's always good. Movement is good to help the brain refocus a little bit. And maybe when you stand up, you might type in something else. You might think about it, because there's so many things that can result in maldigestion and malabsorption, right? So many things. Oh, right. ACEs, right? Those adverse childhood experiences. I see antibiotics popping up, an infection, stress, PPIs, low stomach acid, infection, dysbiosis, right? Imbalance, low bile production, undernutrition. Let me see if you guys wrote that. That's one of mine. The SAD diet, well, that kind of falls in there too, right? The SAD diet that's not sufficient in vitamins and minerals and nutrients, but maybe too high in calories. Stress, surgery, trauma, damage to the villi, celiac disease. Oh my goodness, you guys are amazing. Gallbladder removed, alcoholism, glyphosate issues. Wow. Oh, you guys are so good. Okay, let me think if there's any more I want to talk about. Low bile, surgery to remove parts of the bowel. Okay. And so for the last third, remember we talked about the patient comes in, is it because of issues with pancreatic enzymes? Is it low stomach acid? Or is it issues with bile? Well, how do you do biliary assessment and treatment? That's what we're going to talk about next. Remember those amazing bile salts that the liver produces and that are concentrated in the gallbladder, and bile is really important for fat emulsification, the increasing the surface area of the fat so we can digest and absorb it optimally. Bile is also really important for removal of cholesterol and toxins and waste. What I find so fascinating is that 95% of our bile acids are absorbed back into the blood in the distal small intestine, and the bile acids are reused like 20 times. So, we want to have an optimal enterohepatic recirculation so we can have optimal bile production and utilization. So this is just kind of showing you how it gets reabsorbed in the distal ileum. Again, if there's damage to that area for whatever reason, that's going to influence how much bile acid salts you have. Okay, so what are some signs and symptoms? Maybe there's incomplete digestion or absorption of fats, low fat soluble vitamins, floating stools, diarrhea, bitter taste in your mouth, feeling queasy after a fatty meal, feeling full. Remember, we talked to you earlier that SIBO can deconjugate your bile acids and make them less effective, resulting in more maldigestion over time. So, we have a lot of issues with our gallbladders and gallstones. It's very common, right? So gallstones, the risk factors for gallstones include being female, fat, 40, fair, fertile, family history. Those we learned all about, but also low thyroid function, diabetes, rapid weight loss, morbid obesity, cirrhosis, TPN, total parenteral nutrition, pregnancy. Yeah, I had a little gallbladder pain in pregnancy, actually, but it went away afterwards. High estrogen levels, low stomach acid, all of these things can contribute to problems with your gallbladder and gallstones. And, remember that 60 to 70% of people with stones have no symptoms. And so if you just find gallstones incidentally, you may not need to be moving forward to do anything about them, except for getting your patients on a good whole foods, high fiber, balanced fat intake. And, one of the things we want to work with our patients on is not doing very fast weight loss, because that can always bring that on as well. You can support your gallbladder with bile acids, cholagogues, and choleretics, especially not during an acute attack. So what happens after a gallbladder's been removed? It can wreak havoc. There can be diarrhea post cholecystectomy. It ranges between 2 to 50% of our patients, often improves over time. But when the gallbladder, when there's no gallbladder, the bile salts just continually leak into the small bowel, and it overwhelms the terminal ileum's ability to reabsorb the bile, and then the bile salts will pull water and electrolytes into the intestines and accelerate colonic transit and cause diarrhea. So in this situation, sometimes bile acid sequestrants, cholestyramine, can be used short term and may be helpful, as well as a fiber-rich diet, spreading out the fat in the meal, and maybe even using like ox bile with a meal. Bile acid malabsorption is interesting. This is actually something that I'm always trying to remember when I'm working with my patients who have diarrhea. And I don't want to forget, especially if I'm not making good headway, could this be bile acid malabsorption? It's seen in a quarter to a half of those with chronic diarrhea or who get diagnosed with IBS-D. And there's that may be because the bile salts aren't being reabsorbed into the body because of Crohn's or resection around the ileum or celiac disease, or maybe somebody has excessive synthesis of bile salts or bile acids. So that's actually one of the reasons why metformin creates diarrhea, is because it stimulates more bile salt production. And there are some genetic variations as well. And in addition, our colonic, our microbiome influences how well we reabsorb these bile salts. So it's just something to remember when you've got a patient with diarrhea and aren't getting better. Okay, so here's this. This was a patient of mine who was found to have, she had some gallbladder sludge on ultrasound, and she has this high fecal fat here. And it really indicated to me that I needed to give her some bile salts to help improve her symptoms. So how do you support digestion of fat? You've got your lipase-containing digestive enzymes, you've got your bile salts, and you've got cholagogues and choleretics. So bile salts include like ox bile. You can give it with each meal. TUDCA is a secondary bile salt that can also help with stimulating bile production. And it also has some potentially other good impacts on the body's health as well. And so both of these can be used when you suspect you need extra support there with your patient. Cholagogues are agents that promote the release of bile from the gallbladder, and choleretics are agents that support the production of bile. So things like dandelion root, taurine, limonene, you'll see these in a lot of supplements that are working to support the gallbladder and bile production. And again, when there's an acute attack, you're not just working to use these. You need to deal with the acute attack. There are also foods that impact cholagogues and can increase bile flow. Radishes, dandelion, artichokes as well. Okay, guys, we got another polling question. These are kind of mixed up, so it's not like I'm definitely talking about what we were just talking about here. So, which of the following are correct? Which of the following are correct? Which of the following is correct? Sorry, guys, there's just one correct answer here. I don't want to lead you astray with the way I read it. Which of the following is correct? Just one of these is correct here. And is it high levels of fecal fat indicate SIBO? Decreased pancreatic elastase can be a surrogate marker for increased intestinal permeability. Normal fecal fat will rule out gallbladder issues. Or this last one, these putrefactive short-chain fatty acids, which are valerate, isovalerate, and isobutyrate, are commonly increased with hypochlorhydria. Which one do you think it is? Just one. Just pick one, the best one. The best answer on this one is that last one. That last one is the best answer here, is those putrefactive short-chain fatty acids or products of protein breakdown. You'll see that either one written on a stool test are really indicative of low stomach or inadequate protein digestion. So great job. Okay, going back to my patient here. Does she have issues with bile salt insufficiency? Well, her fecal fat was elevated, but she still had her gallbladder. So I'm not 100% sure on that. So, okay, for the last few minutes, we're going to talk about, before we finish up and go through the case, we're going to talk about motility and elimination. And, this is a really important area for us to focus on. And because so many people have problems with motility and elimination. Remember with motility, there is peristalsis, which is the movement of food through the digestive system when we're eating, but there's also this migrating motor complex. That is the movement of food through the digestive system. It's the sweeping of food and bacteria through the digestive system when we're not eating, right? So when we're not eating, when the stomach is empty,